been angry.
Hi, everyone. This is K&K Healthcare Solutions. We're here with Terry Greenhaulgh. And Terry, if I am totally messing up the pronunciation of your name, please tell me. But
No,
Terry is the owner of T&M Healthcare Consulting, and she's with us today. And we got on a subject that I think that we need to get out at Unfiltered, because orders matter. Orders matter. And one of the things that we see when we read charts and when we review plans of care and when we do things is we see that there's a deficit in understanding what an order should look like. So Terry, tell us what it was we were just talking about that got you fired up today.
well, I was saying that I had reviewed, gosh, maybe near 100 over the past month, records, including plans of care. And there seems to be a fundamental misunderstanding about the role of the 485. It is the foundational order for home health. When we say I got a change order, the change order refers to changing the 485, the foundational order. And I don't believe I found not one wound care chart that had wound care orders. A chart might say apply wound vac, black foam, white foam 3 times a week. It didn't say to where were they applying the wound vac. It didn't. All the orders in the 485 are our orders to put our hands on a patient, put different kinds of products onto the patient, and bear responsibility for that wound care. Those wound care orders in the 485, you need the wound number, you need the etiology of the wound. Is it a pressure ulcer? Is it a burn? What is it? We need to know that. The site, obviously, and for the wound vac, it was the abdomen. We need to know what the wound care orders, and we need to know the frequency of the wound care orders. If those elements don't exist in the 485, you don't have orders. It's not like I'm looking at the 485 and we see these insufficient orders and I see a change order beside it. There are no change orders. There is an insufficient order in the 485. The agency has liability. The nurse who has a license to practice has liability. We have to be more careful. And we need to remember if you have a patient who has a surgical wound, they come to you after their surgery, they may even have gone to rehab for 10 days. We're required to monitor a surgical wound healing by primary intention for 30 days. Even if the patient comes home, the wound looks healed, it's not dressed, we still have to, in the 485, wound number 1, surgical incision to the low back, left open to air, no apparent signs and symptoms of complications. Even left open to air is an order. And we have to, and these patients who had these surgical wounds that weren't dressed, they weren't being, not the wound itself wasn't even assessed in the OASIS or included in the 485. We have to be more responsible with our license and with the license of the agency that we serve. We have to do better. Mm-hmm. And the people in QI need to be looking at this as well. Sorry, Cindy, what's up?
No, I'm just going to say, do you think that this is a result of orders that are templated in the EMR that are incomplete, and so people are just kind of clicking on them and reproducing the issue? Or are they literally free texting orders that are missing key elements?
Yeah, for the ones that I'm speaking about, they're just free texting. But even the ones that, the EMR has a good rollover setup, they're still not in the 485 correctly with all those things, number, etiology, site, and wound care and frequency. But what I do notice with those rolled over wounds, if the doctor's order cleanse with normal saline or wound cleanser, covered with gauze, secure with tape. So every single visit says cleansed with normal saline or wound cleanser. If you did the care, which one did you use? So the rollover feature is great, and I don't understand why people don't take better care of it, because at some point, if I was the owner, I'd want to get rid of that rollover feature, because what I have isn't usable. If I were to to go to have the chart called for an ADR, and they're going to deny it because we don't have appropriate wound care. We're not following the wound care that was ordered. And you go through the whole denial process, you're never going to win because you never did the right thing. You never followed the orders, because cleansed with normal saline or wound cleanser isn't the order. It's telling you to do one or the other.
And it's interesting to me because I want to go back to the basics of something you said initially, that you have to cover your license and you have to cover the agency license.
Mhm.
I look at orders as a former agency owner. I look at orders as permissions. And when you go in to see a patient, we are required to get orders or think permissions to do things to and with a patient. And those orders have to be congealed in the plan of care, which Terry is calling the 485, which I also always refer to as the 485. But just so our listeners know, we're talking about the plan of care document that when we started in home health might have been 2 to 3 handwritten pages. And it was very succinct because it was handwritten. It was succinct to exactly what you were going to do with that patient and nothing more. Because if it was more, you had to do it with your Krampus hand onto that form. And now we see them in excess of 6 and 7 pages, but there is no there. It says a lot of words, but it doesn't say specifically what you're going to do to patients. And Terry's on with us because Terry is our guru when it comes to these charts when they get under review. When they go to the ADR, TPE, to the ALJ process, Terry has been and writing these orders, and this pertains to verbal orders, this pertains to treatment orders after the plan of care, it pertains to all types of orders. What they're doing is they're protecting you from a review later on down the line, but they're also protecting you from malpractice. They're also protecting you from a battery claim because you did something to a patient that you didn't have permission for. So Terry or Cindy, do you guys want to talk a little bit to that and how clinicians, yes, they need to cover the agency, but they also need to cover themselves, right? And their own lives.
I think in not to turn the subject, just to add something to it, you and I had a recent conversation that led to another Unfiltered about how did we get to a point where a clinician cannot identify a focus of care, that they really struggle as we look at those narrative summaries to be able to answer a question that is not a complicated question. I think it's a very basic, why are you there? And by extension, what do you plan on doing with the wound? You need to be that specific. It makes me wonder, and I'm curious what you think, Terry, if kind of those two things intersect in so much of what the clinician is told right now feels very top down. You have to do this and you have to do that and you have to do this other thing, or we have somebody who'll clean that up for you on the back end, or kind of lost their way of I'm practicing, I need to protect my license, that I have a vested interest, that this is not Terry just thinks I need to write more complicated wound orders. It's not you want to read more. Medicare wants more to read. I just feel like clinicians have become far too disengaged in these things, that it's hard to get them to understand this is not about a rule. This is about your license. And this is about being very descriptive, not writing 42 paragraphs or giving us this big description of the one-eyed cat in the corner, but what exactly is going to happen with this wound? What exactly is involved with teaching? I just wonder, because I think there seems to be some just kind of apathy that I don't understand. These are highly intelligent, love their patients, provide good care, but then you look at what they put in writing and it's like, have you lost your mind?
I have a real heart for nurses. They go out and they give their all day long, and they're driving and trying to find a place to go to the bathroom. It's a tough job. And then you do all of that and you come home and you still have so much documentation. And I remember writing nursing care plans and thinking you always had to come up with some really cool sounding nurse words that make you sound brilliant. So when I see my diabetic patient and I have to identify the focus of care, should I be writing it like this? And sometimes we just get ourselves into such a tizzy that we just don't know what we're doing. So I think that's part of it. And then I think, what you talked about with, we don't put enough, but sometimes there is a 7-page plan of care.
Mhm.
Where I think the last record I reviewed this morning, there were only 2 goals for a 9-week frequency. And it said, wound will be healed by the end of the episode. And the other was the wound will decrease in size by 2 millimeters by the end of the episode. So it seems to me that those 2 things didn't belong.
No.
So many things. Again, going back to this is an order. You'll see there was one I looked at, there were 25 interventions, and the frequency was 1 week 2 for nursing. And it was teach patient, I can't even remember now, not to eat hot dogs. Teach patient to weigh daily. Teach patient not to sleep with the window open. I mean, it was stuff like that. And I kept saying you need to consolidate your interventions. Because this is a nursing school. You can't be a home health nurse, but that you've got at least a year of experience. So if I write an intervention that I'm going to teach the patient about heart failure, self-management, including signs and symptoms of complications and actions to take, we all know what that is. All of us nurses know what it is. I don't need to list the 14 things I'm going to teach the patient. If there's something really important, the patient has CAD and angina, I might pull out chest pain as a standalone. Otherwise, we're talking about the self-management of coronary artery disease. But this one, I want to make sure that every nurse knows. We got to make sure he knows what to do if he has chest pain. So that's going to be standalone. Everything else can be general. I've been through a bunch of surveyors, and I've never had a surveyor say to me, that's too general. You got to cover your bases, but
Cover your
you don't
bases,
need
exactly.
25 interventions. You can't do it. So what you've done is the doctor has signed that. So now you have to do and document all those things, or you are out of compliance with your plan of care. What are you going to do then?
So
It's a
I have to make sure in my 2 visits, I'm mentioning hot dogs specifically, or else I did not complete that
Exactly.
intervention.
Right? I
love
told the
what-
patient, go
I
ahead.
love what Terry said, because that goes to writing smarter. It goes to writing smarter. It's not about writing more, it's about writing smarter, and it's about telling the story succinctly. So if you pull out CAD out of cardiac conventions and vital signs per agency policy, blah 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 blah, and you pull out that cardiac, what you're or that chest pain, you're saying that chest pain is at the top of the list of things you're concerned about with this disease process. So I think folks get bogged down in not editing what the EMR already does for them, number one, not making sure that they're covering themselves in the event of something that goes wrong, and also not describing the care that they're actually going to do when they walk in the house. I think that it's super important that if you have those situations that you cover yourself, not just, I used to say this expression, nobody ever died from over communication. Nobody ever died from too many orders. They didn't. And so having those orders in place that change your frequencies, that change your interventions, that bring a social worker into the home, all of those things go back to what makes a verbal order compliant. You have to know who you talk to. You have to know what day, what time, and and that needs to be signed before that bill can be dropped. Or else, if Terry gets to that review process with an ALJ judge, she's going to have, there's no there. Is that there's nothing to defend that chart if these orders don't come on there. There's nothing to defend you if you're in a malpractice suit that you provided meta-honey on a patient that you just said normal saline and cover the wound. Or if you did a wound vac on something that you said was normal saline and cover the wound. You have to make sure you're specific in the instances that it's called for. Do you guys have anything else you'd like to add? Because I'm telling you, we could talk about this for about 3 hours.
Yeah, no, just one more thing. The requirement for the plan of care is that it be individualized, an individualized plan of care. So if I have my guy, he had his left knee replaced, his GU status is within normal limits, he's not incontinent, why am I teaching UTI? Why did I include that intervention into the plan of care? Now, remember, I included it. It's an order. I have to teach on it. Why did I do that? It's not related to the patient. And if I was a surveyor, I'm gonna go look now at all the patients to see if everybody, regardless of need, got taught about UTI. Now I'm looking at an agency that can individualize plan of care.
And that's no hidden fruit. That's always one of the top two reasons why charts get declined and why money is taken back from agencies. That is not following a plan of care is always at the top. That and face to face, which I don't want to get you started, Terry, because I know what'll happen if I mention face to face.
Yeah, there you go.
My thought though, Sherry, I think sometimes what's happened, whether it's orders or the interventions on a plan of care, we've slipped into a path similar to how the industry tends to manage homebound status, which is, as opposed to being individualized and meeting the expectation, which is establishing it at the beginning and monitoring it periodically over the course of care, we make these arbitrary checkbox things, tell them they have to mark it on every single visit, no matter what's going on, mark it every single visit, every single time. And now we have information that does not meet the standard. It talks about can't ambulate more than 10 feet, and then the therapist walks them 75 feet, and you contradicted your reason on the same note. So I think some of the solutions of, you know what, there was this one time, Terry, we missed this UTI and the person went in the hospital. So now we're going to tell every single patient what to look for a UTI. But if the patient had no symptoms, no risk, no problem, that's probably not even on my radar providing the care. So I'm not going to do it because it didn't need to be done. And as you said, I set it up for if it's on the plan, I have to. So I think some of what has been in there is agency attempts to fix things by saying, you always have to put this in, you always have to include this. And it's like, I recommend revisiting some of those alwayses to say, is this really accomplishing what we thought? Or is this setting us up unintentionally for a bigger problem on a survey or an ADR?
Yeah.
And I'm gonna go ahead and cut us a little bit short. Terry, did you have any closing thoughts?
I was going to say from a compliance issue, just what Cindy was talking about, we need to be careful that we're telling our clinicians that they have to do something. I had one DON that we went round and round. She said all women needed to be marked as incontinent. Don't tell your staff to always or never do anything. You risk them saying that you're asking them to commit fraud. And if you're telling them they have to document incontinence, they're telling you the patient isn't incontinent. I'm not sure they're wrong.
Wow, that's a great way to end. And I think that everyone should listen to this over and over again on repeat. And if you hear this and you need to show it to your supervisor, please do. We have no vested interest other than to protect you from an audit or protect you from outside scrutiny. So take this information and please put it into practice. And thank you again for attending another Unfiltered podcast and giving us a place to vent a little bit as reviewers and letting you guys know why it matters. And we'll see you soon. And in the meantime, be safe out there.